Okay, so today we're going to talk about dehydration at 8 o'clock in the morning, and I'm hoping that I can keep you awake through this. There's going to be some interaction, so definitely either unmute yourself or type something in the chat if I'm requesting something. But we're just going to get started this morning, and hopefully the others will join on. So we're going to talk through just a couple of definitions so everyone is kind of on the same page. When you look at different resources and books and literature around dehydration, there's two different words that usually kind of pop up. So we're just going to talk about the definitions of volume depletion and dehydration. So when volume depletion is mentioned in a text, it's really anything that decreases the effective circulating volume. So that could be water reduction or loss of both water and salt. So when you say volume depletion, it means everything that's decreasing your volume. Dehydration really refers to just water loss. So when we talk about dehydration in patients, technically, we should just be talking about water loss, and that should just result in hypernatremia. But we're going to use these terms interchangeably today and just talk about volume depletion in general. We always kind of just refer to that as dehydration, but knowing that there's a difference between the two. So really, when we talk about dehydration today, we're talking about any type of loss of body water with or without salt at a rate greater than the body can replace it. So basically, when you lose more fluid than you take in and you don't have enough fluid in your body to carry out normal function. So we look at patients, obviously, because that's what we're talking about, is dehydration in the context of patient care. There's certain clinical signs that we should be asking about in our histories, or maybe our families or patients themselves will tell us about. And these are really important things to put in your history and physical when you document, and also to talk about when you present patients. So obviously these are listed, and most of you guys are really familiar with this. So this is decreased urine output. So that could be in a baby or infant, it could be diaper counts. In a toilet trained child or older child or adolescent, it could be how many times are you going to the bathroom during the day. The color of the urine is really important too. Sometimes that's hard to see in a diapered child. But when you have someone who's toilet trained talking about the color of their urine, I always tell my kids, and they get grossed out, but I always tell them, if you can see your pee, you're not drinking enough. So talking about the color of the urine is really important. Dry skin, this one can be a little bit challenging because dry skin can be due to lots of different reasons, but that's another thing that you can look for on your physical exam, or even ask the family about. If patients are having problems with dizziness or syncope or near syncope, that can be a sign of orthostasis. So as a result of volume loss. So that's important to ask about. If patients are feeling tachycardic, or if you note they're tachycardic on their physical exam, that can be a sign. Tachypnea is also a sign of dehydration. We'll talk about the reasons for that a little bit later. Fatigue in general, obviously that's kind of vague and can be caused by lots of things, but dehydration can make you feel fatigued. And then confusion and irritability. So this is something that can be, especially in younger children that are irritable, oftentimes that can be a sign of just dehydration. So we usually kind of bucket that into sometimes just meningitis or anything that can irritate the brain. But just remember that when you have decreased volume, you can alter your sodium and you can have issues with confusion and irritability. Does anyone have any clinical signs that I didn't mention that you might want to throw in there, or things that you've seen that aren't listed up on the slide? We must have covered it all. All right, physical exam findings. So remember, we always say about this, but vital signs are vital. So it's really, 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 really important. If you're taking a phone call for an admission, if you're seeing a patient in clinic, and I know we always don't get full set of vitals, but asking for that, if you feel like your patient's dehydrated, asking for a full set of vitals in clinic is appropriate to do. And obviously, if you're in the patient world, we're getting vitals anyway, but paying attention to what those mean. So heart rate, obviously, that's going to be our first sign of dehydration, or at least moderate dehydration in our patients. So tachycardia for age, knowing what age range normals are is important as well. And then knowing when it's abnormal, that could be your first indicator of dehydration. Blood pressure is often going to be the last sign you see. So remember that our patients are very resilient and can hold on to that blood pressure until they meet that cliff that they can fall over. So if you're seeing low blood pressure, then your patient is well beyond moderate dehydration and in the severe range and is in shock. Remember, patients that are febrile, especially our babies and our toddlers that have low surface area, can easily get dehydrated when they're febrile. So evaluating temperature and even history of a fever is really important. Tachypnea. So remember that patients that are dehydrated can be tachypnic, but oftentimes that can be a sign of electrolyte abnormalities, whether it's acid-base status or sodium status. And so remembering to pay attention to that, it could be a clue that something might be messed up with their electrolytes. And then weight is really important. Maybe not so important in an acute inpatient visit where you might not know their previous weight, but if you're in your office setting or in clinic and you have the ability to look back at a previous weight, you can easily calculate how much, what percentage of dehydration they are based on their weight. So for our babies that have open fontanelles, remember to evaluate their fontanelle. And oftentimes when they're dehydrated, they will have a sunken fontanelle. So remember to include that in your physical exam findings. Dry mucous membranes are really important to look for. Oftentimes our patients, our little patients are drooling and all that kind of stuff. So if you're not seeing drooling, or if you look in their mouth and it's really sticky, that's important to note, and it might be one of the only physical exam findings that you find with dehydration. Skin turgor is a little bit different, sometimes difficult to assess, but it's worth trying. So pinching the skin up and seeing if it stays is an important physical exam finding that you can find in dehydration. Cap refill and pulse integrity. This is another very, very important thing. So this is your perfusion. And if you're having alterations in perfusion, you know that you are in the moderate to severe range of dehydration. So assessing their cap refill, it also gives you a baseline to start with as you're rehydrating them, which we'll talk about later, to know when they've restored their perfusion. Sunken eyes and no tears. So oftentimes, especially our little ones, when we're examining them, they're going to be crying because we're strangers and because we're probably doing something that's not fun for them. So if you notice that they're not making tears and they're crying, then you need to note that they might be dehydrated. Cracked lips, obviously, is another physical exam finding. And this one is for Dr. Norton. So if you have a bedside ultrasound tool that you're using either in clinic or in the inpatient setting, remember that you can actually attempt to compress the inferior vena cava and see what the compressibility of it. If you can easily compress the IVC and it doesn't rebound, then you know that the patient is volume depleted. And it's also a good marker as you're rehydrating them, kind of like cap refill of where we are on successfully replacing their volume. Does anyone have any other physical exam findings they want to add in?
Well, sometimes our kiddos in renal failure may not look very classically like this, especially if they have low albumin, so they can look puffy and still be volume down.
Perfect. And so Ashley brings up a really good point. Patients that have underlying disease might not always look dehydrated because they might be volume down, but because of their protein status in their blood, that could be GI, renal. Also, what about some of our patients that have underlying congenital heart disease or even underlying heart failure? What's important for us to evaluate on their physical exam at baseline and as we're rehydrating them? Anyone?
Like lung sounds.
Okay, that's important. So we obviously don't want to overcorrect them. And so if they already have some pulmonary edema, we want to make sure that we are evaluating that, and that might direct our treatment. What other physical exam finding is important to look at?
Capillary refill.
Cap refill, okay. One more I'm looking for.
Melop said for pitting edema for like congestive heart failure and stuff like that.
Okay, yeah, pitting edema. And then assessing their liver. So remembering that patients with heart failure, you want to make sure you get a baseline assessment of their liver, really any patient, because you don't know. Some patients come in and you don't know if they have underlying heart issues, but as you're rehydrating, reassessing that liver, and if you're starting to see hepatomegaly, then that means that you probably need to back off on your fluid resuscitation, or there might be something going on with their heart that they can't handle the volume. So that's another important physical exam finding, not really to assess if they're dehydrated, but to know what their baseline liver is as you're rehydrating them. Okay, so common causes of dehydration in pediatrics, and a lot of these are just kind of self-explanatory. Oh, I'm gonna go back. So a lot of our kids will come in with gastroenteritis, so they'll have history of vomiting or diarrhea, and our little kids easily get dehydrated with gastroenteritis. So making sure you take that history. Fever, like I mentioned before, patients that are smaller have lower body surface area and will easily become dehydrated with just insensible losses from fever and tachypnea, that type of thing. Remember that our patients with burn are burn-like illnesses. So anything that disrupts the skin integrity, so that could be a true burn, but also patients with staph scalded skin, or if they have horrible atopic derm, like we had a kid last week with eczema herpeticum, her entire skin integrity was disrupted because of her horrible open lesions. So remember that will increase their risk of dehydration, and you will need to give them more fluid. And then obviously patients with diabetes insipidus or diabetes mellitus, that can be good causes of dehydration. Some patients that are on medications like diuretics or others that can induce diuresis can come in with dehydration. And then kind of like we mentioned earlier, patients with underlying renal disease or liver and heart failure, any type of systemic inflammation like we're seeing here lately with our MIS-C patients and Kawasaki and that type of thing. And then GI diseases that give you more of a protein losing enteropathy will third space. And so they will be intravascularly volume depleted, even though they might look puffy. And that's because of their shift in albumin. So just remember that when your albumin's low, your fluid's going to go into the wrong place. And you will actually be volume depleted intravascularly. Okay, so when we talked about the different clinical and physical features and different causes of dehydration. So how do you assess your patient? So when you're looking at different percentages of dehydration, because that's you need to know that to be able to calculate your fluid replacement, you want to look at two different things. So you want to look at the degree of volume depletion. And so if you're fortunate to have a baseline weight on your patient, so if they're one of your patients in clinic, or if they're one of a frequent flyer in the hospital and you happen to know what their baseline weight is, then you can easily calculate that percentage. But most of the time we do not have that available on patients, or their parents don't know what their normal weight is. And so we're having to use different physical exam features and clinical signs to really determine what percentage of dehydration that they might be. And so when we talk about patients that are dehydrated, we can use things that we just mentioned. So usually mild dehydration is going to be 3 to 5% dehydrated. And most of these patients are going to have a reduction in their urine output, but they will have a normal physical exam. So they should not have dry mucous membranes. They should not have, they should still have tears. They should still have all those things, but they might just have a decreased diaper count or just not peeing as much and have a history that reflects some mild dehydration. Once you move into moderate dehydration, which is 6 to 9%, dehydrated, patients will start having vital sign abnormalities and physical exam findings that you will be able to assess. So those patients should be tachycardic. Sometimes they'll have orthostatic changes in their blood pressure, and they'll have decreased skin turgor and dry mucous membranes, and they'll start to have an extension of cap refill. So not 4 seconds or more, but kind of that 2 to 3 second range is usually for moderate dehydration. And then obviously your severe dehydration is going to be 10% or greater. And these are patients that are in shock. So their blood pressure is low. They have exaggerated cap refill. They will probably have some pulse alteration. And those patients will be kind of obvious, but it's really those moderate to mild that you want to make sure you assess with your clinical exam findings. There's a good article that talks about clinical dehydration scale. So this is a scale that can be helpful and has been validated for use in patients that are 1 to 36 months of age. And because these patients can be hard, right? They're not really verbal. They can't tell you a lot of things. Sometimes their physical exam findings won't always be exaggerated, and when they're in the mild to moderate range. So this is a scale that you can use if you would like to be able to score patients and place them into a category. And you'll see that table off to the right of the slide. And so this uses just general appearance, eyes, their mucous membranes, especially their tongue, and presence or absent of tears. And so you can use different things that you see on your physical exam and give them a score and then place them in a category. So if they score none of those points, that means they're not dehydrated. If they score 1 to 4 of those points, they fit the mild category. And then 5 to 8 is either a moderate or severe. You should be able to see severe dehydration pretty readily, but it will help you with the mild to moderate ones that might be a little more difficult. So that's another tool that you can use. And so after you've determined what percentage of dehydration they are, you want to also kind of think about maybe what type of fluid they've lost. So remember, if they have GI illnesses, which a lot of our kids are going to present with, they're not only going to have water loss, but they're probably going to have sodium and potassium loss. And then if you're just presenting with an overall illness with fever, that type of thing, usually that's just going to be water loss. So why do we care? What are the consequences of dehydration, and why are children more susceptible? We've already kind of talked about their higher surface area to volume ratio. So that means that any type of illness with fever or tachypnea or anything where their body systems are being revved up, they're going to have greater insensible losses and more likely to get dehydrated. Also remember that a lot of our kids are either not developmentally able because of their age, or maybe because of developmental delays, to express thirst. And so they're not able to say, I'm thirsty, or my mouth feels sticky, or I'm not peeing a lot, or things like that. And some patients don't have access to their own fluid. So most toddlers and lower, or if they're have neurologic consequences and are delayed, won't be able to just go get a drink of water on their own. And so they easily get dehydrated because of that reason. If you think about when you have worked out or been outside, or something that's caused you to be a little dehydrated, you recognize when your body's thirsty and you just go get a drink of water. So we're able to monitor our own hydration status pretty easily, but children can't often do that on their own. So why is this important? Remember that our body volume, makes our body work. So it affects our end organs, especially our liver, kidney, heart, brain. And so when you don't have the volume to circulate blood, then you lack perfusion to those organs. Also, changes in sodium, especially rapid changes in sodium, can have temporary or permanent neurologic injuries. So that's also another important thing to note. And then these are some things we're going to be talking about later, but remember that dehydration can lead to electrolyte abnormalities. So you can have hyponatremia, which is usually because of an inadequate or inappropriate fluid intake. So these are patients that are taking in hypotonic solutions, and we'll talk about the appropriate solutions to take in when you're dehydrated in just a little bit. Hypernatremia. So that is because of the loss of free water. So most of our patients are going to present, if they have electrolyte abnormalities, are going to present with hypernatremia. If patients are vomiting, then they can lose potassium in their emesis and have hypokalemia. And then acid-base balance. So patients that are acidotic, that can be to lactic acidosis just from poor tissue perfusion. Or if patients are having severe diarrhea, they can also be acidotic from that. And then remember also, if your patient's vomiting, a lot of times they'll end up with a contraction alkalosis. Okay, so you've assessed your patient, you can determine the percentage of dehydration. Now, what do you do about it? So remember that there's not a whole lot of diagnostic workup to dehydration. Obviously, if they have an underlying cause, or if you're concerned about something else, then you're going to be getting other things. But most of our patients will just need a couple of labs to determine if there's been any consequences of dehydration. Remember, if your patient is only mildly dehydrated, you do not need to get electrolytes. And so if you can assess patients and know that they're at least moderately to severely dehydrated, that's when you need to start getting some lab work. And this can be in the form of a BMP or a renal function panel, so that you can look at their sodium and potassium and their acid-base status. Some patients as well, it can be helpful to get urine studies. So if you're concerned about DI, or if you just want another marker of dehydration, you can look at specific gravity if you can't get blood on a patient. But usually we're going to stick with electrolytes plus or minus some urine studies. All right, treatment. So there's 4 different methods of treatment, or phases of treatment, I guess I should say, that we'll talk about. And the first one is going to be how you replace it. So remember, in patients in general, there's multiple ways to get fluids in. So this can be intravenously, right? You can get a peripheral IV on a patient. You can put a central line in a patient, which usually only if they're in shock, we recommend doing that. There have been studies on subcutaneous infusion of fluids. So giving a normal saline bolus along with hyaluronidase, either in the back of a patient or in the extremity of a patient, can slowly infuse a bolus. We don't typically do that in our hospital, but some community hospitals that don't have maybe access to vascular access teams, or don't have an ICU, or want to avoid a transfer just for access, will sometimes use this as a method of giving a bolus to a patient. Remember that we have our intraosseous method. So obviously we're not going to use this first line, but in patients that you're having a hard time getting access on, or they're in severe trouble and you need to get fluids in, remember that that's an option too. So we have IOs on our code cards. I know Dr. Edwards teaches you in your simulations on the inpatient side on how to do both manual IOs and use the drill. And so this should be something that we're comfortable with and familiar with using as well. And then don't forget that patients have mouths and we can feed them or put a tube down their nose or mouth to be able to feed their bellies. And so for patients that are having a hard time getting IV access on, and you can use their gut so they're not persistently vomiting, or you're not worried about an acute abdomen and need to keep them in PO, you can drop an NG tube or an OG tube and you can give IV fluids in their belly at the same rate that you would infuse IV fluids in their IV. So don't ever forget that's an option when we're running out of ways and you want to try to avoid putting a central line if you don't need to. So the first type of therapy that we're going to talk about is repletion. So this is, you guys know this. This is the type of therapy that's going to restore the patients to their normal volume and normal electrolyte status. So the first part of this is emergent correction. So this is using your IV fluids and boluses. This has to be IV if it's emergent correction, and this is to restore their perfusion. And then the rest of the repletion of fluids, depending on their severity of dehydration, can either be by IV or PO. So we'll talk about that a little bit. And then obviously maintenance therapy just replaces ongoing losses and maintains normal volume and electrolyte status. So this is when you've achieved normal perfusion, you are normal in your electrolytes, and then you can start maintenance therapy on these patients. So repletion therapy, we talked about emergent repletion. So this is based on the degree of their hypokalemia. So if they're severe, if you've calculated their hydration status or their dehydration status, and they are in the severe category, then you're going to be giving 20 per kg boluses of isotonic saline. This is going to be rapid. So if they are severe, you're either going to be using the push-pull method, which I'll show you a video on in just a minute, or you can use a pump, and that is run wide open. Remember, in pediatric patients, we do not use pressure bags. So maybe in our adolescents and older, we can use those, but we do not use pressure bags on our smaller patients. So this will be push-pull or wide open on the pump as fast as you can run it. And then obviously you'll want to reassess and continue to bolus until your perfusion is restored. So part of that reassessing is obviously checking their cap refill, but also checking their liver and listening to their lungs to make sure they're handling the volume appropriately. And we usually will give boluses up to 20 cc's per kg. If they're moderately hypovolemic, usually we don't have to use emergent repletion. You can always give a bolus to improve their cap refill, but usually this is not going to be emergent in the push-pull method or using a pump wide open. And it could be in the form of PO or IV, depending on their ability to take PO. Remember that when we're repleting fluid, this is always going to be isotonic crystalloid fluid. So we're not going to use cryo or albumin or anything like that. We're going to use normal saline or LR to use for repletion. All right, I'm going to show you a video. And this is just demonstrating the push-pull technique. Remember when you're in our ED or in our PICU, not sure if they use this in the NICU or not. These are methods that you can use on patients to give rapid fluid boluses. On our floor, we do not have these stopcocks available just on the regular floor. So if you're wanting to give a push-pull bolus on the floor, it's usually going to be along with the rapid response team. They have stopcocks in their tackle boxes, as we call, and there's also stopcocks on the code carts on the floor. But usually your routine boluses are using on the floor, you're not going to be using this method. So this video is just a few minutes long, and then we'll kind of talk about it.
Hey everybody, we are here today with Stephanie from Carolina. She is one of our PEDS coordinators here in the emergency department, and we're going to talk about a push-pull method for IV fluids for kiddos. So if we can give rapid fluids to kids. So I'm going to have her step in.
Hi guys, I'm Stephanie. I'm our PEDS coordinator here in the One thing we're going to talk about today is a gap we've identified is giving fluids to kids rapidly. So I'm going to show you today how to use the push-pull method and giving kids fluids rapidly. One thing we've identified is that when physicians are ordering a fluid bolus, we're not always questioning whether or not we should be just running on a pump, which is one way to give it, or two, to push the fluids. So those are the two ways. We don't do wide open on kids and we don't do pressure bags on kids, but you can push fluids and you can run them on pumps. What I would tell you is definitely if a physician just gives you a verbal order, ask them. Ask them how fast they want it. It's possible that maybe if they're going to plan to give a couple fluid boluses on a kid, they want the first one pushed and the second one infused. So ask them how fast they want it. Definitely always do what your mark tells you to do, but one thing is you should probably question whether or not you should be able to push some fluids. So I'm going to show you how to do the push-pull method, and that is to give kids fluids rapidly. Grab a normal bag of saline, prime it with your normal IV tubing to the end. Then you're going to grab a stopcock, which is kind of one of my favorite little tools. It's just kind of useful for a lot of different things. You're going to connect it to the end. We're going to pretend this baby has a scalp IV already established. And then you're going to grab a 20 ml syringe. So I would say a 20 ml syringe if you're going to use if you're giving a 20 per kilo bolus. If you're just doing a 10 per kilo bolus, use a 10 ml syringe. It's just going to help you for math. So thinking through it, if you're going to give, if I'm using a 20 per kilo bolus, I have a 20 ml syringe, then I'm just going to give as many syringefuls as this kid is in kilos. So let's say this is a 2 kilo baby, and I'm going to give 2 syringefuls. You're going to hook your syringe up. Let's just say we're going to finish priming it, make sure that all the way the stopcock is primed. And you're going to literally connect it to you can connect it right directly to the IV. And you're going to turn your stopcock off to the patient first. And this is just so that you're not pulling back a blood and you're actually just pulling straight from your tubing. So I'm going to pull back my syringe. And you can see, like, I already am getting my syringe directly from the fluid. And then you're going to turn the stopcock off to the fluid so you can push it in your IV. And it's going to go right into the IV and give the kid the first bolus, first part of it. So like I said, we're going to give, this is a 2 kilo baby, so we need 2 syringefuls. So you're turning your stopcock back off to your baby. Pull back again for your fluids. Just turn that stopcock back and forth. So it'll say off. Just make sure it's turned off to the direction that you're either pulling or pushing. So now turn it back off to the fluids, and now it's open to the patient. And I can give my second bolus. So now I've just given this kiddo a 20 per kilo bolus in a matter of a few seconds.
All right. So that is push-pull. So remember when you are giving orders for IV fluid boluses, to be really clear in your orders. So if you say IV push, that means that you mean a push-pull method. If you just say IV infuse, then that means infuse on the pump as fast as the pump can go. And using that communication with your nursing staff is important. So once you have emergently repleted fluid for your patient, you're going to want to complete the repletion of that fluid. So this is just completing and getting back to normal volume status for your patient. And this is going to be determined by the serum sodium concentration. But both methods of ORT, of oral rehydration and IV rehydration are actually fine to use. And actually oral rehydration is the preferred method of repletion of therapy in our patients. There's sometimes where we have to use IV. So this is if our patient cannot take PO. So if they're in PO for some reason, or if they have something going on where they're physically not able to take oral fluids, then we would have to use IV. If you have a caretaker that you just can't trust, or maybe is not present, a lot of our kids are even in the hospital, their caretakers are not there. And so if you don't have someone at the bedside to push oral rehydration, then you're going to have to use IV. If your patient is persistently vomiting, so if you're doing PO challenges and they're not succeeding with that, then obviously you're going to have to use IV. And then if they have severe electrolyte abnormalities, you're going to want to use your IV fluids first, but until their electrolyte abnormalities are almost normalized. So let's talk a little bit about oral rehydration therapy, because I feel like we jump a lot of times to IV hydration and forget that we have a great way of getting fluids in patients, and that's actually more effective. So this takes advantage of passive intestinal water absorption. And if you're using solutions with equimolar concentrations of glucose and sodium, then these are actually as effective as IV hydration. So you can use oral rehydration therapy for both mild and moderate dehydration, obviously not for severe, for repletion. But if patients are mild to moderately dehydrated, then for the rehydration phase, or the repletion phase, you're going to want to replace their fluid deficit over a 3 to 4 hour time frame. And so this is with very small volumes. You can give them a 5 or 10 ml syringe. And every 1 to 2 minutes, you're giving 5 to 10 cc's of fluid. And this is either orally, if the patient is compliant, and you can do that, or you can do this NG on a pump, or with just little boluses with your family member. And then obviously maintenance phase or just their normal daily needs, plus repleting their ongoing losses. So remember, if patients are having large blowout watery diarrhea, you're going to want to replace 10 cc's per kg of fluid for each of those stools. And if they're having large emesis, you're going to want to replace 2 cc's per kg. So just keep that in mind as well. But these are really good instructions if you're in clinic and you want to do oral rehydration with your patients, giving these instructions to parents, calculating the ounces that they need to take for each diarrhea or for each emesis, if they're able to continue to keep fluids down, and giving them instructions on rehydrating them if they are dehydrated and you want to avoid IV fluids is a appropriate way to do that. These are just some suggested oral rehydration properties. You don't have to memorize those, but you do need to know off to the right what are appropriate and what are inappropriate solutions. So if you think about our clear liquid diet in our hospital, those are not fluids that we would use for rehydration. They're great fluids for once you've restored your volume status and you want to do maintenance. They're great things to start out with as kind of a bland, clear liquid diet, but they're not appropriate for rehydration. The solution that we're most familiar with that is appropriate for rehydration is something called Pedialyte. But there are also different forms of this too that are commercially available. You can get these on Amazon. That's Sterilite, Imphelite, Rehydrolyte, and then obviously the World Health Organization formulations. If you've ever tasted these, they're not so great, especially the World Health Organization products. The flavor is not so awesome. So sometimes you can mix this with just a little bit of juice to help the flavor. A lot of the like Pedialyte and Imphelites will come in flavored solutions that won't mess up the osmolarity, that you can encourage families to use as well. Does anyone have any questions about the oral rehydration solutions or methods?
I do, Dr. Blackburn.
Go ahead.
So would we like backdate this in a patient who said they came in, like say the patient came in, they had 5 episodes of diarrhea before they got to the hospital. Would we just add on that right now? Or would we just be like, we'll put you on maintenance now, and then if you have another vomiting or something, we'll give you Pedialyte or something like that?
Yeah, so that's a great question. So I would say when they're coming in, you assess them for their dehydration percentage. And if after those several episodes of diarrhea, if they're moderately dehydrated, then you're going to replete their fluids based on their level of dehydration as you're seeing them. But as they continue to, so as you're seeing them and you've repleted their fluids and you're calculating ongoing losses and maintenance fluids, that's when you're going to add on those additional either diarrhea episodes or emesis. Does that make sense?
Yes, thank you.
Any other questions?
I have a question, Dr. Blackburn. Wondering, in your opinion, under the adequate solutions, is there any one solution that you prefer, you think is superior to the others? Are they all essentially equivalent?
I mean, Pedialyte is the one that we have available to us most readily, not only in the hospital, but on shelves. If you look at, store shelves, there's lots of different flavors of Pedialyte, and it's something that's really recognized. But if you have savvy parents that want to go on Amazon and get some of these solution packets and mix them themselves, that's great. If you're traveling, if you're doing medical mission stuff, I've used a lot of the WHO packets because they are small and you can mix them with a clean water source or wherever you are. So that's the benefit of some of them as they come in the powdered packet solutions that you can just reconstitute versus having to carry around big jugs of things with you. Any other questions? Okay. So when we're looking at maintenance fluids, what do you choose? So a long time ago, back when I trained, we historically used a lot of hypotonic solutions for patients when we were choosing maintenance IV fluids. We calculated their average salt need based on kilograms. And a lot of patients were either placed on quarter normal or half normal IV fluid solutions if they were smaller. And what we found from that is we created a lot of hyponatremia iatrogenic in our patients. And so a few years ago, the AAP came out with clinical practice guidelines around maintenance IV fluids so that more of a standardization in prescribing practices could happen. And that when you standardize products, that helps with the ability of hospitals to stock certain products and have things readily available for you based on use, but also obviously to decrease harm in our patients. So to prevent iatrogenic hyponatremia in our patients. And so when they did this, when they did the studies and released the guidelines, this applies to patients that are a month of age to 18 years of age. So it doesn't include our neonates, which we do our fluids a little bit differently in them. But once they hit a month of age, up to adolescence and past, this particular guideline is applicable. They also included patients with some underlying disorders. So underlying neurosurgical disorders, cardiac disease, hepatic disease, cancer, renal function, DI, lots of watery diarrhea, severe burns, and NICU patients. And that's just because their sodium levels will probably be a little bit abnormal, and you're going to have to do something different with their maintenance fluids. But for the most part, these guidelines will apply to the majority of our patients coming in the inpatient setting for maintenance IV fluids. If you look at this table, it gives you the composition of commonly used fluids in comparison to human plasma. So human plasma has a sodium content of 135 to 145 milliequivalents. And if you look at the solutions that we have available to us, even in our IV fluid order sets, quarter normal is going to be 34 milliequivalents of sodium per liter. Half normal is going to be 77. And then our normal saline is 154. Lactated ringers is 100, and Plasma-Lyte, which we don't use a whole lot, is 140. So LR is actually a little bit hypotonic, and normal saline is a little bit hypertonic, but a little more close to what our human plasma is to begin with. So really the key action statement from this particular set of clinical practice guidelines is most patients within a hospitalized setting should be using normal saline, obviously with or without dextrose, depending on their age and underlying condition, for maintenance IV fluids. They did not use lactated ringers in this study, so there's no comment made on that. I know sometimes we use that in certain situations, but just remember it is slightly hypotonic, but still may be an appropriate thing to use in some of our patients. All right, let's get into some electrolyte correction and some calculations, and then I'll have you do a few problems before we end. So when we're looking at hypernatremia, we want to ask these questions. So what is our volume status? How much free water needs to be given? What type of fluid and what rate needs to be ordered? Are there ongoing losses that need to be addressed? And what is the underlying cause of hypernatremia? So we'll go through each of these a little bit. So when we're looking at volume status, you want to make sure you understand how to calculate free water deficit. So for patients that you're either calculating their percent dehydration based on weight, or you're doing it based on their physical exam findings, you can easily land on a number. If you're doing it by physical exam findings and can't get a actual number, then using 5% for mild, 7% for moderate, 10% for severe is an appropriate thing to do. And so in patients that are moderate to severe, you're obviously going to be getting renal function panels and evaluating their sodium status. So this particular formula is how you calculate the free water deficit. You're going to look at their total body water. And so that is 0.6 times their current body weight to calculate how many liters of total body water they have. You're going to look at their total fluid deficit. So using their weight and their percentage, how many liters or milliliters they're down. And then using this formula based on their serum sodium to see what their free water deficit is. Once you have calculated the free water deficit, you'll take their total fluid deficit, which is a liter in this case for this patient, and subtract that free water deficit to get what is remaining that you need to, what their fluid replacement is. Obviously, if they've gotten any saline boluses, you'll subtract that out. And then you'll use that to add on your maintenance fluids and ongoing losses to see how much total volume that you need to replace in your patients. And we'll go over an example of this in a little bit. So remember that normal saline is actually hypotonic in patients that are hypernatremic. So it is usually a safe. Did someone have a question? If you're not muted, then go ahead and mute your computer. I'm hearing some background noise. Okay, so remember that normal saline is hypotonic in patients that are hypernatremic. So in general, this is actually a very safe type of fluid to use for replacement. And also remember that patients that are hypernatremic, you're going to want to replace their fluids over 36 hours so that you don't lower the serum sodium too quickly. And really the goal is to lower the serum sodium less than or equal to 0.5 milliequivalent per liter per hour. And that's so you don't get those huge shifts in your brain and have some neurologic complications. I'm going to skip over this calculation because you don't really always need to use that. Okay, we've kind of talked about replacement. So remember that 10 cc's per kg is for any large watery diarrhea, 2 cc's per kg for MSS. And then you guys know how to calculate maintenance fluids using the 4-2-1 rule. So I won't go over that. And then looking at treatment of specific etiologies, obviously most of our kids that come in dehydrated are going to be related to their acute illness, but obviously they might have underlying DI. So making sure that you're looking at the labs appropriately and taking a good history to see if that needs to be treated as well. Okay, so here are some of the other electrolyte abnormalities you can have. Obviously hyponatremia, and remember, usually this is because they're giving the wrong type of fluid. So if you are, a patient comes in and they have been dehydrated and the parents are giving water and juice, then that's probably the reason for their hypernatremia. And that can lead to altered mental status and seizures. Sometimes if the patient has underlying neurologic or respiratory issues, it could be due to SAADH, but that's going to be more of a rare occasion. Hypokalemia, there's a few different ways you can replace that IV or PO. So K-phos, KCl, and K-acetate in the IV are ways that you can use additives to replace potassium. And then if patients are acidotic, remember that sodium acetate and sodium bicarb are ways that you can replace that in the IV fluids. So usually we're going to say if the pH is less than 7, you want to use bicarb. If it's greater than that, it's fine to use acetate. All right, let's get to a few examples in our last few minutes that we have, and this is going to require some interaction. So we'll see how far we get. So a 2-year-old patient presents to the clinic with 2 days of vomiting and diarrhea. On exam, she has dry mucous membranes and is not making tears. Her weight at her last well check was 15 kilograms and her current weight is 14 kilograms. So the first question is, what percentage dehydrated is she? And you can open up your mic or type in the chat.
By calculation, it's 7%, 14 divided by 15.
Perfect. So if she's 7% dehydrated, would she fall into the mild, moderate, or severe range?
Moderate.
Good. Okay, so knowing that she has moderate dehydration, would you obtain any diagnostic workup? Let's give
Can
you
we do
two.
an, I'm sorry.
Go ahead.
Can we do an RFP?
Yeah,
Especially with that
so-
diarrhea?
Yeah, so remembering that she's moderate, moderately dehydrated or worse, right? If she was moderate severe, we would get some electrolytes. And then how would you treat her? So you're in clinic. So what are some ways that you can give her fluid replacement in clinic?
You could try some.
Elop wants to give her Pedialyte.
I think that's appropriate. So remember, she's moderately dehydrated. We can do some replacement with a syringe as long as she's not vomiting. And it sounds like maybe she's stopped vomiting. Okay. In our clinic, sometimes we can always give a normal saline bolus too. Not all clinics are going to have that ability to do that. So remember, if you're in a true private practice setting, you can do, if you have some time to wait there with the family and they're willing to do it, you can do some oral replacement in your office with Pedialyte. Okay. Next example, a 16-month-old presents with the ED with fever and decreased urine output. He appears drowsy with sunken eyes and dry mucous membranes. His heart rate is 160 and his blood pressure is 60/40. So how would you assess his level of dehydration? And I've given you a nice little chart to use right there. Anybody want to chime in?
Do you mean like mild, moderate, or severe? I would
Mhm.
say this one is severe.
Okay, so I agree. So if you use the clinical dehydration index off to the side, because he's within that 1 to 36-month age range, he meets criteria for severe dehydration. So what is your first step in treatment, knowing he's severe?
20 cc per kg bolus push-pull.
Perfect. So you're going to start out with either push-pull or on the pump as fast as you can run it. Start with your boluses and reassessment. And then after you have emergently repleted him and his perfusion is normal now, what is your next step?
Reassess and start oral hydration.
Right. So this is when you're going to calculate your total deficit, see what you've already given in terms of normal saline boluses, and then determine what you have left in your repletion, if you have any ongoing losses, and then add in your maintenance fluids, determine how much volume that you're going to need to give over the next 36 or so hours. All right, and I'm going to try to squeeze in this last one. That's going to involve some math for you guys. So you have a 10-kilogram patient who is 10% dehydrated and has a sodium of 152. He has received 2 normal saline boluses of 20 cc's per kg and has restored perfusion. What fluids will you run? All right, so you can remember, calculate the free water deficit for this particular patient. So remember, free water deficit is the total body weight or total body water times the serum sodium over 140 minus 1. And remember, when you're calculating total body water, it's 0.6 times the weight. Anyone have that? I'm going to type the equation in the chat if you don't remember. And I'll give you a hint. Her total body weight or total body water is 6 liters.
Melop got half a liter.
Okay, so close. Yeah, so 514 milliliters exactly is her free water deficit. Okay, so once you've calculated that free water deficit, how do we see what her isotonic loss is? So if she lost 10% of her weight in kilograms, that means she's a liter down, right? So a liter minus 857 is 486. So that's really her total fluid deficit minus her water deficit. Okay. And I'll tap this in the chat. If you calculate her replacement needs, then you will look at that total fluid deficit minus the water deficit, which is going to be 486 milliliters. And then you're going to subtract out her boluses, which how much fluid, if she got 20 per kg times 2, how much fluid would that be?
Assuming they used her not corrected weight, that would be 400.
Good. So if you take that, then that's the rest of your replacement that you're going to need. So you're going to take your 86 milliliters plus any ongoing losses that she currently has, plus your maintenance, and you're going to take that volume and divide it over 36 hours for the rate. And remembering that in hypernatremic patients, normal saline is actually hypotonic. So it's safe to use as long as you're monitoring their sodium and making sure you're not dropping them quickly. And you can obviously do all those fancy sodium calculations, but that's a quick way to do fluid replacement by just looking at percentage dehydrated. I know we're at time. Does anyone have any questions about dehydration or doing fluid calculations?
So where did you get the 486 from again?
If you subtract, sorry, I tapped in the wrong thing here. But if you subtract 1,000, the 1,000, which is the total amount that she lost because she's 10% dehydrated, she's a liter down, minus 514, that will give you 486. So the total fluid loss minus her free water deficit is 486. I'll put that in the chat too. Any other questions? Okay, y'all have a great day.